Hi, my name is Dan, and I'm a mental health pharmacist, and today I'm going to be talking about the psychopharmacology of antidepressants. So I have 5 major objectives that we'll cover today. First, I want to talk about the indications for using antidepressant medications. This is just a few brief slides. It won't be all encompassing, but to set the scene for what we'll be talking about. Then I'm going to review how to select an antidepressant for your patient, and I'm going to go through some recent guidelines for antidepressant medications, so depressive guidelines, and then I'm going to talk about some clinical evidence, so just one trial. Next is the bulk of the slides, which is choosing an initial antidepressant, and then after that we'll do how to address follow-up, and finally do a few cases to apply what we talked about. So first, for the indications for antidepressant medications. This first slide here is for depressive disorders, so that includes major depressive disorder and then premenstrual dysphoric disorder. As you can see, for major depressive disorder, there's a lot of different medications that are FDA approved to treat depression. You'll note that a few of them are blue, and those are ones that have pediatric indications, so under the age of 18. They're varying ages, but all the ones in blue have some pediatric indication. Next is anxiety and related disorders. You'll see here that there's not as many as were approved for major depressive disorders, but for something like generalized anxiety disorder, you can go off-label. So if you want an SSRI, your options aren't just Escitalopram and Paroxetine. Prescribers often go off-label in this case. Again, the blue indicates a pediatric indication. Panic disorder and social anxiety disorder are also included here. Next is some other indications. So OCD has a lot of pediatrically approved medications. And then you'll notice with something like post-traumatic stress disorder, PTSD, there's just 2 that are technically FDA approved. But again, this is another situation where prescribers often go off-label. That being said, some of these other conditions like fibromyalgia, you could potentially try a different SNRI other than Duloxetine, but going too far off-label wouldn't be common here. And then smoking cessation, it would be uncommon to use another product other than bupropion in the antidepressant class for this indication. So the major takeaways here are that some of the indications and some of the FDA-approved indications for different conditions, you can go off-label, whereas with other conditions, you want to remain on-label. So having that knowledge is important. The final point here with the indications is when not to use an antidepressant medication. So in disease states like bipolar disorder, you would not want to use a antidepressant medication because this has the chance of flipping the patient out of depression and into mania. And then personality disorders, there's some evidence that some of the medications can be helpful, but generally you want to rely heavily and really push for therapy. So for example, someone with borderline personality disorder would benefit from dialectical behavioral therapy over one of these medications. Okay, so we understand the indications and how you can sometimes go off-label and how you sometimes can't. Now let's review how to select an antidepressant for your patient. We'll start with guidelines. So brief slides here about the Veterans Affairs Department of Defense guidelines from 2016, and then the Canadian guidelines also from 2016. So I didn't include the APA guidelines, which is American Psychiatric Association guidelines, because they were last updated in 2010, so they're considered outdated at this point. So here are the VA DoD guidelines. You can see I have it separated through the columns: first line, second line, third line, and treatment resistant. I think the guidelines are helpful here for a few reasons. So first is to look at when you have a treatment resistant patient, you can use the guidelines to remember things that aren't commonly used. So like transcranial magnetic stimulation, you can see here as treatment resistant, ECT, and then some of the medications you wouldn't commonly see. They're also helpful from a first line perspective because you can see that they're pretty broad. So they don't really it's not like an algorithmic approach where you have to use one medication, then another, then another. It's more broad, like use a medication in this class. If that doesn't work, try another medication in this class. Also to note here, for mild depression, St. John's wort is included as an option, and that can be used, but remember that St. John's wort is a CYP enzyme inducer at 1A2, and 50% of prescription medications on the market go through the CYP1A2 enzyme. So you have a chance that you can lower your levels of other medications with St. John's wort. So be really careful with the interactions there. Only use that if the patient really wants that approach and doesn't have any interacting medications. But then for the first line, moderate to severe, there's therapy on here, which is fantastic. And then also the medications are pretty broad, like I was saying. So SSRI, SNRI, bupropion, mirtazapine are the first line options. The Canadian guidelines mirror that pretty closely. So for mild depression, they have psychological treatments, St. John's wort again. And then when it comes to pharmacotherapy first line, it's pretty broad again. So SSRI, SNRI, except Levomilnacipran, bupropion, mirtazapine, Vortioxetine. So it's fairly broad, but that can be good or bad. And then the guidelines are again helpful when it comes to treatment-resistant depression. So if we've tried a few things and nothing's working, check the guidelines at that point for guidance. Okay, I wanted to review one trial. So the STAR-D trial is a famous trial published in the New England Journal of Medicine in 2006. So it had 3,000 participants, and it really mirrored real-world scenarios. That's why it's so commonly cited as like the main trial known about for antidepressant medications. So level 1 was pretty standard. They started with an SSRI medication, so that's selective serotonin reuptake inhibitor, Citalopram. And the patients were on this, each level was 12 weeks long, so pretty long trial. If that didn't work, then the patient went to level 2. And the part that mimicked real-world scenarios here is that the patient had that choice if they wanted to switch, which medication they wanted to switch to out of the ones that were available, or if they wanted to add on a medication, which medication they wanted to add on. So it wasn't like blinded or randomized. It was giving patients the choice, which is what you want to do and what is done in real-life scenarios. So level 1, 12 weeks long, level 2, 12 weeks long, so there was a potential to switch the medication completely if the citalopram wasn't working for you, or add on a medication if citalopram was working a little bit, but you wanted additional benefit. Level 3 also had a switch group and add-on group, and then level 4 used tranylcypromine, which is an MAOI, or venlafaxine plus mirtazapine. So here are the results of the STAR-D trial. Level 1 had roughly a 30% remission, level 2 had a 25% remission, level 3 20% remission, and level 4 10% remission. Which makes sense because our medications work by increasing the effects of serotonin, norepinephrine, and or dopamine. And once you try a few medications, it's just the little nuances and difference between the medications that is changing. The overall effects are very similar between the different medications. So if one doesn't work, then another might possibly not work as well. It's hard to tell, but maybe try a different mechanism. Okay, so we talked about the indications, we reviewed the guidelines briefly, and talked about the STAR-D, how it followed like a real-world scenarios. Now I wanted to get into the bulk of the presentation, which is choosing an initial antidepressant. So as you can see on this slide, this is not all the antidepressants that are out there, but this is a fair amount of them. So there's over 30 options, so it can be extremely hard to pick out of all the options. And you saw from the guidelines that they're pretty broad. They say pick an SSRI, pick an SNRI, a few of the other options. So it's pretty broad. Right off the bat, we can eliminate half the medications as the initial antidepressant. You're not going to use an adjunctive medication because you haven't started anything else yet. MAOIs and TCAs, although effective, have more side effects. In TCA's case, more fatal and overdose. So they've fallen out of favor of the first line options. So already we've eliminated half the options and the big spectrum to choose from becomes more manageable. Next, we can eliminate a few more medications for the initial antidepressant that are newer, brand name, less studied, could be more expensive for the patient. So that's Fetzima or Levomilnacipran, Vilazodone or Viibryd, and Trintellix or Vortioxetine. So as you can see, there's 3 more dashes of medications taken away. Next, we can eliminate 2 more. So Fluvoxamine, although it would work, it's not FDA approved for major depressive disorder in the United States. It is in other countries. It's just approved for OCD here in the United States. So I eliminated that option. And then Trazodone. So Trazodone is primarily used in lower doses as a sleeping medication, and it can be used for depression, but you have to split the dose throughout the day. It's sedating and makes people tired and isn't commonly used for depression anymore. So that leaves us with 10 options. So we went from over 30 down to 10 for your initial antidepressant choice. And now let's go into some of the medications. So the first column was SSRIs, which stands for selective serotonin reuptake inhibitors. So they increase the effects of serotonin. These are often first line due to their side effect profile. So they're relatively safe in overdose. It's rarely fatal when they're the solo agent used in overdose, and less fatalities, so 0.5 risk compared to SNRIs, which was 2.5, and the TCAs, which was over 13. There are some class side effects related with the SSRIs. So it's affecting serotonin in the brain. There's a lot of serotonin receptors in the brain, so headaches can be an issue, especially when starting an antidepressant. Also, interestingly, there's a lot of serotonin receptors in the gut. So GI effects are common, which stands for gastrointestinal effects. So something like stomach ache, nausea, vomiting, diarrhea can occur. Again, with headaches and GI distress, this is usually transient, which means once your body gets used to it, in general, these side effects will go away. So you just want to pay attention, special attention to this when you're starting a new medication or increasing a dose. 2 sides of an opposite coin, insomnia or fatigue. So it can cause trouble sleeping or it can cause you to feel too sleepy. There's sexual dysfunction where, as if you have a patient with a lot of anxiety, they may not bring this up on their own. So it's important to ask about this side effect when you're talking to your patients. And then weight gain can occur. So as for the individual SSRIs, first we have Citalopram or Celexa. So the normal dosing range is 10 to 40. What makes it unique? For all the medications, I bolded what I think is the biggest takeaway for each medication. So Citalopram used to be prescribed past 40 milligrams. It showed some QTc prolongation, which means that it has some effects on the heart that can be serious if the dosing is too high. So we stop at 40 milligrams nowadays. Slightly more fatal than the other SSRIs in overdose, but still relatively safe compared to other medications. So the biggest takeaway with Citalopram or Celexa is that it's an SSRI with a good and bad enantiomer. So our Citalopram has slight antihistamine effects, so it can make people sleepy, and also gets in the way of Escitalopram binding. So you'll see here the dose is 10 to 40 milligrams, but our next medication, they isolated the S enantiomer, called it Escitalopram, which makes sense, or Lexapro, and the dosing is 5 to 20, so cut in half, because it doesn't have that other enantiomer getting in the way of it binding. What makes Lexapro unique is it's the quintessential SSRI. So it has minimal other binding sites, and it's considered one of the more clean SSRIs. So it binds and affects serotonin and not too many other things. There's fewer drug interactions than compared to other SSRIs, and it's considered really well tolerated. So this is often a good starting place for a medication. Next is Fluoxetine or Prozac. So the dosing range here is 10 to 80 milligrams. Interestingly, when you do an internet search for Prozac, a lot of book titles come up. So Prozac Nation, Prozac Diary, and more. So it's on a lot of book titles, really prevalent in culture, I guess. What makes it unique is it has a really long half-life. So the parent drug has a half-life of 2 to 3 days, and it has an active metabolite of 2 weeks. So what this means is One, it's basically self-tapering, so there's less withdrawal effects, which is now called discontinuation syndrome effects. And the other side of that, though, is when you increase a dose, it takes quite a while for that full effects to be seen in the serum. So remember the long half-life. There's also some 5-HT2C antagonism, which causes small increases in norepinephrine and dopamine release. So this can help someone with concentration, but maybe could be a little too activating and cause some issues with falling asleep. Next slide, we have fluvoxamine or Luvox. So this was the one I was saying that's not technically approved for depression in the United States. It is in other countries, so it's not commonly seen in the United States other than sometimes for OCD. It has more enzymatic interactions than other antidepressants, so if this one is being chosen, make sure you do a drug interaction check. Next is paroxetine or Paxil. So there's a lot of unique components with Paxil. Its normal dosing range is 10 to 50, but there is an XR version as well. I don't see the XR version all that often, but it is available. It has mild antimuscarinic properties, so dry mouth, constipation, sedation, all the antimuscarinic effects. And it also has weak norepinephrine reuptake inhibition. So you can kind of think of it like a weak SNRI with more side effects. It also inhibits nitric oxide formation, so that can contribute even worse to sexual dysfunction. And it inhibits its own metabolism. So when you look at when the levels rise in the serum and when they start to fall, it's no longer available to stop its own metabolism, so the metabolism shoots down, the levels shoot down, which can cause the withdrawal, the discontinuation syndrome effects. So Paxil is really known for its withdrawal effects as well. And it has slightly more drug interactions than other SSRIs. So there's a lot of potential negatives with paroxetine or Paxil, and that's why I don't see it quite as often as some of the other options in the SSRI class. Next we have Sertraline or Zoloft. So not a lot to say about Zoloft. It's used a good amount. The dosing range is seen there. What makes it unique? Mild dopamine reuptake inhibition. It also has some sigma binding, so there's some unique parts with Zoloft, but it may have a little bit of that improved motivation and concentration and a slight bit activating. Next, moving on to the SNRIs. So this is serotonin and norepinephrine reuptake inhibitors. So we're going away from the SSRIs, which are just affecting serotonin. Now we're affecting serotonin and norepinephrine. Often first or second line. Generally, I see them more second line after SSRIs have been tried. Class effects are similar because it affects serotonin just like the SSRIs, but I wanted to add and highlight increased blood pressure, so that can be an issue with SNRIs. They're relatively safe in overdose, more fatal than SSRIs, but a lot less fatal than the TCAs. So the first one we'll be talking about is venlafaxine or Effexor. So its normal dosing range is seen there. There is an ER product, which is used much more commonly than the IR product. What makes it unique is that at lower doses, it primarily acts like an SSRI, affecting mostly serotonin. Once you get to moderate doses, it has some norepinephrine reuptake effects. And then if you go high dosing, past what is generally the max and generally accepted, it has some dopamine effects as well. So it's like this full spectrum antidepressant that can affect serotonin, norepinephrine, and then even sometimes dopamine. Just like with SSRIs, how Paxil is known for its discontinuation syndrome, out of the SNRIs, venlafaxine is known for its withdrawal effects, its discontinuation syndrome. So if you have a patient on this that wants to stop, make sure to lower the dose and taper them over time rather than just cutting it off. This also, since it's an SNRI, can cause the hypertension and sweating and those norepinephrine effects. Next we have desvenlafaxine or Prozac. So this is an active metabolite of venlafaxine. I don't see it all too often, but I do see it. The dosing range you can see there is 50 to 100. Next we have Duloxetine or Cymbalta. So I do see this a lot. This is a pretty common medication. The dosing range is 40 to 120 milligrams. less hypertension and milder withdrawal compared to venlafaxine, so it has that benefit there. But it's often used for pain. So the norepinephrine component can help with various pain syndromes, so like fibromyalgia, neuropathic pain, things like that. Duloxetine can be a good choice. Monitor for liver disease. So in patients who have a history of using alcohol, this wouldn't be a good option. Or if a patient just has any liver disease or liver dysfunction, this wouldn't be an option you would choose. The final SNRI that I wanted to talk about is Levomilnacipran, or Fetzima. What makes it unique is it blocks norepinephrine much stronger than serotonin. So this big gap between the norepinephrine effects and the serotonin effects. Its effects are fairly weak in the evidence. So when it was approved by the FDA, one of the trials only found a statistical significance in the highest dose for response. For remission, there was no difference compared to placebo. So I don't recommend this medication very often. I've very rarely seen it used. It has weak effects. It may help with pain. It may help very, very tiny bit with depression. So not a medication I see very commonly. Next, let's go into some of the medications that don't fit cleanly into classes. So we'll start with bupropion or Wellbutrin. There's different products. So the IR version is dosed multiple times a day. The sustained release version is still dosed twice a day. And then the XL version is the most commonly seen one because it's just once a day. So someone with depression, you don't want to put more things on their plate than they already have. So make their medication regimen as easy as you can. So once a day is best for every case pretty much. So the XL version is what you want to see, what you want to use here. What makes it unique is it doesn't affect serotonin like a lot of the other antidepressants do. So it's a norepinephrine and dopamine reuptake inhibitor. And you may worry about abuse potential since it's affecting dopamine, but generally you need at least 60% occupancy of dopamine receptors for it to cause those euphoric effects and be really well liked. And bupropion doesn't get to that 60% threshold. So it's below that. It's not commonly abused, so it's a good option. It does not cause sexual dysfunction because it doesn't have that serotonin binding, but the issues would be you wouldn't use it in underweight patients or patients with a history of seizures because it can provoke seizures. It is also used for smoking cessation, which is fantastic. If you have a patient with depression who also is trying to quit smoking, then this medication would take out both of those issues. And the final benefit with bupropion is since it works differently, it can be an adjunct medication to SSRIs or SNRIs. So it gives you that additional option to augment therapy with it. Next we have Mirtazapine or Remeron. Its normal dosing range is seen here. 7.5 is the starting dose. You can go up to 45 milligrams. This is taken once a day at bedtime because it's sedating, it causes people to feel sleepy, and it can cause some weight gain, so a difficulty there. Although it works on serotonin and norepinephrine, it works in a different way than SSRIs or SNRIs, so it can also be used as an adjunctive agent and use it in addition to SSRIs, SNRIs, which is a good benefit. There's also less sexual dysfunction, and it can potentially even treat some of the sexual dysfunction caused by SSRIs or SNRIs. Trazodone is also a medication in other. So this medication works differently. It has the serotonin reuptake effects, but it also has serotonin antagonism at 5-HT2A and 2C. It blocks alpha-1 and histamine, so it makes people sleepy. So you'll see here on this slide, the dosing for depression is 150 as the starting dose, whereas when we use it for sleep, you start at 50 milligrams normally. So we'll see patients on 50 or 100 milligrams, and you're not even at that bare minimum for depression yet. So separate in your mind when you're using this for sleep at those lower doses, or if you rarely are using it for depression, you're going to have to increase that dose to get the effects that you're looking for. Next we have Vilazodone or Viibryd. I don't see this medication very commonly. Its mechanism is basically that of an SSRI plus 5-HT1A partial agonist like buspirone. So SSRIs are relatively inexpensive medications. Buspirone a relatively inexpensive medication, but this is combined in one pill, Vilazodone, and it's a relatively expensive medication. So I consider this a villain, and I don't recommend this unless a lot of other medications have been tried, because you can get that same mechanism a lot cheaper just through 2 different pills. Also, the final note with this, must be taken with food, or you'll have 50% less absorption, and therefore you're basically taking half of a dose each time you're taking it. Next is Vortioxetine or Trintellix. This medication is pretty interesting. It has a complicated mechanism, so it does have the serotonin reuptake inhibitions, but at the serotonin subtypes, it does a lot of different things. It has a long half-life, and it has potential pro-cognitive benefits, and that was both in rat trials and in human trials. So that's where I see the greatest potential for Vortioxetine. Maybe an older adult with depression, starting to have some memory impairment or cognitive decline, but we need more evidence to support that. Also of note, the brand name used to be Trintellix, but the FDA deemed that that was too close to Brilinta, so they made the manufacturer switch the name, and now it's called Trintellix. Next, I wasn't going to go into the individual medications for tricyclic antidepressants rather than group them together, because they're still used a fair amount, but often for indications other than depression. So they block serotonin and norepinephrine, so they're kind of like an SNRI minus the selective part. So they increase the effects of serotonin and norepinephrine, but they're a dirty drug and bind a lot of other places. So histamine blockage, which can have side effects, sedation, weight gain, blocks muscarinic receptors, which can cause anticholinergic symptoms, and alpha-1 blockage, hypotension, dizziness, also can contribute to the sedation. The final part to know with the tricyclic antidepressants is that they're cardiotoxic in overdose, and sometimes as little as a 1-week supply can be fatal. So due to those effects, they fell out of favor. So someone with depression or who has a history of overdosing on medications or is having suicidal thoughts, then giving them an agent that can be fatal in overdose isn't the best choice. So that's why these fell out of favor compared to SSRIs, SNRIs, which started to take over. Next, we have the MAOIs. These irreversibly inhibit MAOI-A and B, which metabolize serotonin, norepinephrine, dopamine, trace amines, all these sorts of things. The reason that this fell out of favor is there's dietary restrictions. So there's tyramine in foods that cause the release of norepinephrine. The average person can handle 400 milligrams of tyramine, but you can only handle 10 milligrams when you're on an MAOI. So if you eat something like cheese pizza and beer, or maybe have some wine or some fermented foods, your blood pressure can skyrocket if you're on these medications. It's called a hypertensive crisis. So patients who are on these medications really have to restrict and pay attention to their diet, which is just too complicated when we have other options like SSRIs or SNRIs where you don't have to worry about the diet. Okay, so back to that original slide of showing all the antidepressant options and how we eliminated so many. And now, since we talked about the intricacies of the 10 different recommended starting medications, we can start to make some patterns and see which medications we want to prescribe for our patients. The final thing I wanted to consider is sedation versus activation, and then weight gain. So one of the good things with this is that sedating medications and medications that cause weight gain often go hand in hand. So sedating medications like Mirtazapine and the tricyclic antidepressants also cause more weight gain. And then if you look at the activating medications, bupropion, it causes less weight gain. And then the SSRIs, SNRIs are somewhere in between there. So some can be more sedating, some can be less, some can cause a little more weight gain, some can cause less. So that's the final piece of the picture. So if someone's having trouble sleeping, you would pick something that would help them sleep. And if someone was having the opposite, you would pick the opposite. So this slide is kind of like my overall ideas about selecting a medication, and this is based on my experience and based on my interpretation of the evidence, so feel free to disagree or deviate from this, but this is how I approach medication selection. So generally, if I see a patient that has already been recommended therapy, has already done lifestyle changes, wants a medication, I'll start with an SSRI. The one that I like to start with the most is Escitalopram or Lexapro, because remember, that's the quintessential SSRI, and it is relatively a clean medication. It's not binding to all these other things. If I want something that's slightly sedating, sometimes I consider Citalopram. If I want something that's slightly activating, I can do Sertraline, and then if I wanted a little more activating, Fluoxetine. If I want to choose an SNRI, that's a good option if the patient has pain and controlled blood pressure. So the most commonly used ones I see here are venlafaxine or duloxetine. And then finally, bupropion and mirtazapine are also both commonly used. So bupropion is the activating side, also is used to quit smoking, and then mirtazapine is on the sedating side if someone can't sleep with depression. Okay, let's go into how to address follow-up. We're through the bulk. The third objective was the longest objective, but now I wanted to do follow-up, and then we'll do some cases. So the first thing to take into account is when to have follow-up. And I base this off of three major things. The first being age. So patients under the age of 24 have an increased risk of suicidality when starting an antidepressant. So if the patient's under 24, I want to see them back very soon. If the patient's more severe with their symptoms of depression, I also want to see them back very soon. And if the patient's having anxiety, I want to see them back soon, because anxiety can increase and get worse before it gets better when you start an antidepressant medication. The next thing to think about is the response of a patient to the medication when you're addressing follow-up. So it's easy if the patient has no response and they were on it for an adequate amount of time at an adequate dose, you just switch medication. It's not working for them, they have no response. It's also best to use a scale. So use a different type of, you can use any type of depression scale to track objectively what their score is over time. It's also easy if the patient goes into remission, because then you just continue treatment. The patient's doing well, their symptoms of depression are almost completely gone, continue treatment. Where you have to make a choice and it becomes more difficult if the patient has response, so they're improved, but they don't have remission. They're still having a lot of symptoms of depression. So here your first option is increased dose. You really want to maximize one medication that the patient's on rather than complicate their medication regimen. But sometimes there are specific reasons where you can't increase the dose anymore, or the patient's on the maximum dose and you have to augment. So no response and remission are easy to solve, but response, you have to make a decision. So how do we address adjunct medications? And we talked about this a little bit. Make sure the dose is maximized, or make sure there's a specific reason to add another medication. So some principles here are you never use more than one SSRI or SNRI in combination. So you wouldn't use Lexapro with Effexor. That combination wouldn't be common in practice. It would definitely raise some eyebrows. Sometimes you can add a low-dose TCA to other conditions if the patient's stable with their SSRI, SNRI use. Sometimes you can add lithium. More commonly, you would see aripiprazole, which is also called Abilify, to the SSRI, SNRI medications. And then in the often category, bupropion and mirtazapine are commonly used as adjunctive agents. And then trazodone is commonly used for insomnia. So that wouldn't be necessarily frowned upon if someone's on an SSRI and low-dose trazodone is added for sleep. Okay, finally I wanted to end with 3 cases to apply what we talked about. So case 1, 20-year-old male presents for an annual checkup. He endorses increased sadness, minimal interest in his hobby of woodworking, his appetite has been decreased, and he doesn't feel like cooking food. Sometimes he has trouble sleeping, but not every night. His symptoms have been going on for the past month or two. He is not interested in therapy, but will try medication. He states he was on Lexapro when he was 18 for depression, but only took it for a few weeks. What do you recommend? So the first thing I think about here is, why did this patient stop the Lexapro? If it was due to side effects, then that might be something I would shy away from. The patient was 18 at the time, so there's a lot of compliance issues in younger people. Maybe he started to feel better. Maybe there was some other reasons he didn't pick it up from the pharmacy, or he didn't get a refill or something like that. So if the patient didn't stop Lexapro due to side effects, then I would probably consider starting that again. So it's, again, that quintessential SSRI. It's a good starting place, so Escitalopram could be used. He has some trouble sleeping, but not every night, so you could consider Citalopram, which has slight antihistamine effects, slightly sedating. You could also consider Sertraline, but that might worsen his sleep. You also could consider Mirtazapine to help with sleep, but also note that the patient's 20. There's more weight gain with Mirtazapine, so those long-term weight gain risks would be on my mind. Okay, next case, you are seeing a 51-year-old male with a past medical history of major depressive disorder, hyperlipidemia, and alcohol use disorder. He has been taking Fluoxetine 40 milligrams for 2 months. His PHQ-9 score, which is a depression score, has decreased from a 19, which is moderately severe depression, down to a 10, which is only moderate depression. He has been having sexual dysfunction, but is hopeful and wants his mood to improve. What do you recommend? So if you took away the sexual dysfunction from this case, what you would generally do is increase the fluoxetine. So the patient's at a moderate dose of fluoxetine, has had a response to the medication, but you want the patient to continue to improve. But the patient's having a side effect, so sexual dysfunction. If you increase the fluoxetine further, the sexual dysfunction could get worse. So at this point, you really have to have a really good conversation with the patient. How severe is the sexual dysfunction? Is this something that you're managing and you're okay with, or do you completely want it gone, switch medications? So if the patient's doing okay, has some side effects, but it's not too severe or doesn't happen too frequently, you could augment and keep the patient on the fluoxetine, but augment with Mirtazapine and bupropion. Or one or the other, which both have evidence that they can help treat SSRI-induced sexual dysfunction. If the patient completely lost faith in the fluoxetine and you want to get rid of it, a good starting option would be the bupropion, which wouldn't have any sexual dysfunction. Or if you wanted to stick with the serotonin effects / norepinephrine in this case, you could do Mirtazapine, which has less sexual dysfunction than SSRIs. Okay, final case, 55-year-old female, mother of one adult son, presents to the clinic for treatment. She has been previously treated at an out-of-state free clinic and recently moved here. She has been experiencing sadness, has little motivation to leave the house, and increased anxiety. She has a distant history of a suicide attempt 7 years ago where she took 20 over-the-counter Unisom pills. She has no history of migraines or neuropathic pain. Her Beck Depression Inventory 2 score, which is a depression scale, is 21, which is moderate depression. Her current medication list is seen below. So Sertraline 25 milligrams, amitriptyline 25, Mirtazapine 7.5, and ibuprofen 800 twice daily. How do you address her medications? So the first thing to note here is this is often seen in real life practice where you'll see a patient on a little bit of this, a little bit of that, a little bit of this. So she's on 3 antidepressant medications at low doses. The Sertraline 25 is an SSRI, the amitriptyline 25 is a low-dose tricyclic antidepressant, and Mirtazapine 7.5 is a low-dose antidepressant as well. So I highlighted before that she has no history of migraine or neuropathic pain. So my first thought would be get rid of the amitriptyline, specifically if she's taking it just for depression. She has a history of overdosing on medications, and again, TCAs can be fatal in overdose, so I would want to get this away. Next is, then I want to clarify between the sertraline and the Mirtazapine, which one the patient found more beneficial. So the patient might say, oh, I didn't notice too much of a difference with the sertraline, but the mirtazapine really helped me to sleep at night. I started to feel a little bit better. So then in that case, I would narrow in on the mirtazapine, probably cut the sertraline as well, and increase the dose of the mirtazapine. Whereas if the patient said, I've noticed more of a benefit with the sertraline, I would do the opposite, cut the mirtazapine and increase the sertraline. So now we have the patient on one antidepressant and we're attempting to maximize that dose. If the patient notes that they had some benefit from sertraline and mirtazapine or some of the combination of medications, that's where it gets more complicated. Do you want to really zoom in on one medication, but the patient's endorsing a few different medications are helpful? Regardless, she still has moderate depression on this regimen, so some change needs to take place. Okay, so we talked about the different indications, how for some indications like generalized anxiety disorder, you can go off-label, whereas some of the pain conditions, you really want to stay on-label. Then we talked about the guidelines, how they're really broad in the first line options. So they basically say pick an SSRI, pick an SNRI, or pick bupropion or mirtazapine. We discussed the STAR-D trial to see that like stepwise approach to treating depression. And then we went through the bulk, talked about some of the intricacies with the individual medications. We talked about how to address follow-up and when you want to see a patient more sooner. And then we did a few cases. So my references can be seen here, and I hope that presentation was helpful.